Good morning, good afternoon, or good evening, everyone, and welcome. Thank you for joining us for the 8th session of the PRESOD webinar series, which today takes the form of a panel discussion on the topic, how can we assess the added value and impact of OneHealth prevention strategies? It is now my pleasure to introduce today's panelist, Dr. Osman, Senior Advisor at Africa CDC and member of the OneHealth High-Level Expert Panel, Professor Wanda Markotter, Director of the Center for Viral Zoonosis at the University of Pretoria and co-chair of the OneHealth High-Level Expert Panel, Dr. Marc Leandri, Associate Professor of Economics at Université Paris-Saclay, researcher at UMI Source IRD, and invited researcher at the Agence Française for the Development, and Dr. Yoeri Booijink, OneHealth Economist at CIRAD and member of the Community of Practice on the OneHealth Return on Investment. Today, the discussion will be moderated by Dr. Christina Pettan-Brewer, Global OneHealth Leader at the University of Washington School of Medicine and member of PRESOD Steering Committee. She will now introduce the topic and guide today's conversation. Christina, the floor is yours.
And it's wonderful to be here, an honor to be here with all of you and the audience. And I just want to remember all of you to go and check again the webinar series at the PRESOD website, because it's fantastic how many topics will join together with the topics today. And also look at the PRESOD website, how to become a member as well, since it's a global movement. So I just want to welcome all of you, and also we're going to have very good insights and discussions today, but I just wanted to give a little background in why we're here today. So it's the prevention of pandemics. Prevention of zoonosis and pandemics encompass various dimensions and time horizon. Primary prevention addresses the biological, social, and ecological drivers that shape health outcomes, intervening upstream before the disease even occurs in human populations. Secondary prevention, by contrast, focuses by detecting and containing disease once it has emerged, mitigating harm and limiting its spread. At its core, prevention means reducing the probability of pathogens spillover from animals to humans. This requires identifying the key leverage points within complex human, animal, plants, and environmental systems, and act where intervention is most effective and sustainable. With PRESOD, and I will just remember you what is PRESOD: preventing zoonotic disease emergence. We adopt a systems thinking One Health approach. This demands a complete understanding of the ecological, epidemiological, social, and economic factors that enable pathogens to cross the species barrier, as well as the governance and behavioral dynamics that influence the risks. This webinar today will examine how to define and measure indicators capable of capturing the impact and added value of prevention strategies. Our amazing speakers and experts today will share their experience on existing indices, frameworks, and cross-sectoral indicators spanning health, environmental, and socio-economical dimensions, while addressing methodological challenges, data availability, equity considerations, and the prevention paradox, while also discussing how indicators can inform decision-making, finding, and accountability. So let's start for this wonderful debate. And to all of you speakers today, let's talk a little bit about starting with the indicators in prevention to give a little background. What do you consider an indicator in the context of zoonotic disease prevention? And are we talking about risk reduction, system transformation, economic returns, behavioral change, or something else? So the floor is open. Somebody, Wanda, would you like
I can
to start?
start. Hello, everyone, and thank you for the invitation to join this webinar. I think it's quite a loaded, complicated question. I want to go back to some of your introductory remarks, because if we do talk about this, we need to really understand what we're talking about in terms of prevention of pathogen spillover. And I'll go back to a definition that Ola published on a paper of prevention of spillover, where it's really about shifting disease control from reactive to proactive. And that's what we mean with primary prevention. So it's not just about thinking a pathogen is present or not. It addresses a lot of other issues like drivers of disease emergence. And that's where the ecological climate, your anthropogenic factors comes in. And that increased spillover risk, because there needs to be contact between where the pathogens are in nature, in the source host, and where it's going to spill over. And this is the drivers that creates that contact interface. So I think if we think about indicators, it needs to focus on reducing that contact between humans and the infected animals and their environments. And that will be where some of these indicators can be focused. But then you also want to lower the pathogen prevalence in animal hosts if you can. So if you know there's pathogens present that has the potential to spill over, you can look at health of animals and some other ways of reducing that load, managing high-risk interfaces. So we've seen with a lot of these zoonotic diseases, sometimes it's linked to wildlife trade, sometimes it's this livestock interaction or intensified farming, land use changes. And overall, if you strengthen ecosystems and biodiversity protection, then you will also reduce the opportunities for pathogens spillover. So if you talk about indicators, I would say, you can't probably only choose one. It's also very context specific in certain areas. Not all of these things will apply. It may be a very specific interface of contact that you need to look at. But there's wildlife and ecosystem health indicators, there's ecological integrity, surveillance in pathogens, there's livestock and agricultural interface indicators, human behavior and exposure indicators. That's probably most of the time missing in frameworks that we will talk about today. And then all your environmental land use things that you can look at that are drivers of disease emergence. And then I think it even goes broader, and we can discuss that, but you need to look at things like health systems, your intergovernmental systems, your intersectoral systems that needs to be in place if we look at indicators. Otherwise, the information will not be shared and it will not be collated together. So maybe just a few very broad comments from my side that we can dive deeper in some of the next questions. Over.
Yeah, no, those are very great introduction. Osman, would you like to share some of your experience, please?
Yeah, I mean, I just I suppose I echo everything Wanda said. She's covered a lot, but perhaps just to add that an indicator should be understood as a measurable signal that tells us whether the underlying drivers of disease emergence, and these can be, as sort of Wanda was saying, they can be upstream and quite distal to the actual spillover event, or they can be more proximate and closer to the spillover event, and whether or not these drivers are changing in a way that either reduces or increases the risk. That's what an indicator is telling you. And so you can sort of group them as well. Traditionally, obviously, health system indicators have focused on disease outcomes, deaths, hospitalizations, cases. But we're talking about stuff that's much more upstream when we're talking about prevention, and particularly prevention of spillover. So there's, as we said, the ecological, environmental kind of risk drivers. And these are things like, I don't know, anything from the density of livestock production systems to deforestation to sort of land use change. But then there's also the second category, which is the system readiness and resilience, right? So this is your system to deal with spillover events. So these are, the level of integration across sectors, your laboratory diagnostic capacity, things like that. And then finally, you can have a third category of behavioral and governance change, sort of related indicators. And this is Um, and this is then, the sort of more downstream human societal measures that can be taken. So improve farm biosecurity, safer, wildlife trade practice, human preferences around the kinds of foods and consumable, goods that they want. I mean, you could even argue that some of our, luxury goods that we want, if you want fur coats and these kinds of things, these are all consumption-based human societal demands that then drive spillover events because of how we then model and shape and develop our economies. What are the things that we demand and how risky are they in terms of how they then relate to spillover downstream? Yeah, I'll pause there.
And that's fantastic. We can see it all the way from the consumer, from the prevention, from the source. So it's the connection. And since you just mentioned economy, please, Marc, bring us the hardest one, economy.
Yes, well, I'd be very happy to complete what my colleagues have just mentioned with maybe a slight different take on what do we actually need those indicators for. And this could be another way to group them into categories. And maybe this time I will just merge primary and secondary prevention that's been mentioned before by Wanda to show that you might need ex-ante indicators when you're trying to decide on whether or not you want to act, or what kind of strategy prevention you actually want to implement. And those can be returns on investment, for example. And to give a very concrete example, when you talk about rabies control, if you hesitate between a strategy that would be only the post-exposure cure of humans and a strategy that would be a vaccination campaign for dogs and an awareness campaign for humans, then you can look at your indicator ex ante to try and find which one would have the better return on investment. Second, you have process indicators, which is basically the way you can measure if your project, if your prevention initiative is actually being implemented correctly. And there can be something very concrete, such as the number of workshops you've organized with farmers on one side, or the number of meetings you had with a coordinated health sector. And those will help you follow if the prevention is actually put into place. And third, ex post, you have impact indicators, which are going to be very important when you want to prove that your prevention has been successful. And we'll come back to that, obviously, with the paradox of prevention that Christina mentioned before. But those kind of indicators can be used ex post. And I'll try also to give some concrete examples. If we're talking about prevention in the most health system approach, then it can be the change in the number of cases, in morbidity, metrics like this. But if we come back to spillover prevention, which we really want to include in the discussion today, then you can maybe look at a proxy, such as the area of land that hasn't been deforested, that you've spared from deforestation. And then this proxy can be useful to quantify, in a way, the prevention, the spillover prevention action you've put into place.
Yeah, this is very good. Thank you for bringing us the whole metrics, which is always very important. And then Yoeri?
Yeah, I think most of it is obviously already mentioned. And I think this also raised part of the issue that we're facing, how to select the right indicators to show the value that we need to make decisions on prevention. And there is also the availability of the case of data availability. Sometimes we simply do not have the data to show what we need to show. And this is why it also has an advantage that it is such a wide landscape of what we can choose from, because if we can link something to drivers of spillover, there's a way to show the value in a different way, and the challenge will always be to select those indicators and to present those to make the case to show this true value of prevention. So yeah, that's why it's quite interesting in how to deal with these indicators and how to interpret the outputs that we get from them. So it's a broad landscape.
Well, that's good. That's why we're here. And since we're going to learn how to select the indicators, let's continue a little bit thinking about, despite the prevention paradox, how can we demonstrate impact when success means that nothing happens? Any one of you would like to share?
I think Osman was tasked with this one.
Was I?
Back to you, Osman.
I thought, yeah, so you're giving me the easiest question, right? How do we prevention paradox? So obviously, prevention paradox is sort of one of the central challenges of in public health. But I think there's two ways to think about it. One is firstly that there's actually a mindset around prevention, right? And this is often affected by culture as well. So there's a cultural mindset amongst policymakers, decision makers, politicians around prevention. And with some things, it's just accepted as part and parcel of how we develop and operate our society. So, for example, in the military, every country will have a standing army, and this is particularly relevant now, given the global context of what's happening around the world. But if you have a strong military, that is seen as and that is seen as a deterrent to war, right? And so there's a prevention of armed conflict, and that's just an accepted reality that yes, obviously we have to have a standing military, and the stronger it is, the less likely we are to actually have to end up in a war or end up fighting and being part of a cycle of death or whatever. So that's a cultural adaptation in that it's just an accepted fact within society, and you'll find that as well in other areas. So, for example, around the use of health insurance or travel insurance among some cultures, it's quite common practice that they buy into the idea of health insurance or travel insurance, and everybody gets it. It's just part of the cultural norm. In other cultures, it's completely alien. It's, why would I spend money on something when the risk of something happening is sort of 1 in 10,000? I'll just take the risk and do it. So I think firstly, there's this idea, especially within public health, that it's a matter of continuous education, both amongst society, but also amongst particularly your policymakers, decision makers, and funders, that prevention is important, and there are these real risks that are being prevented, even if you don't necessarily see them. And a lot of this is then also obviously based on historical incidents, historical outbreaks, keeping that alive in the memory. As many of you will know that, in the immediate aftermath of a pandemic or an outbreak, it's all very fresh in the memory. There's funding available. Everybody's talking about recovery. Give it a couple of years or a few months, one or two other issues, and suddenly everyone's forgotten about it. It's downgraded, it's defunded, it's deprioritized, and we forget about it. So part of it is that continuous educational process, that these are real risks and they do happen. They might be low probability, but they are high impact. So that's one side of it. The other side of it is that rather than starting to measure impact around disease outcomes from a prevention perspective, it's important we start thinking about indicators that are measuring changes in risk trajectory, sort of, as well as system resilience. And I think that's the way we can then start thinking about impacts, right? So first we measure spillover risks and its drivers. Everything from ecological disruption that increases the likelihood of emergence to things like pathogen circulation in animal populations. Then we measure system performance. So assuming that we are interested in preventing spillover events, it's important to be measuring the system performance. How quickly, what is the time from pathogen detection to reporting? How effective are your laboratories? What are their capacity? And then, of course, the third is because economic incentives are so important and opportunity costs are so important, the avoided costs through economic modeling are another really important element that's critical to measure when you're trying to influence policy and decision makers. The last point I'd make around this is that what's also really critical is that we get much better at examining, especially because given we have a cross-sectoral view of things within the OneHealth community, that might get much better at measuring co-benefits as well as trade-offs. So if we put in place this intervention, what is the risk? What is the trade-off? What am I not investing in, right? So that gives you a sense of the true cost of a particular intervention around prevention of spillover. But then you also have to then measure the co-benefits, right? If there's a benefit to the human health sector, what are the co-benefits to animal health? What are the co-benefits to the economy and to the environment? And how do we ascribe a value to those? So that itself is a whole area of study, which is actually, in many ways under investigated. How do you put a value on the environment, or a clean environment or ecosystem well-being? These are both economic and quantitative questions, but also qualitative and societal questions. What are the values that we're using and ascribing, and how are we equating them across sectors? But I think, yeah, I'll pause there. But those are some of the issues with the prevention paradox.
Yeah, you brought very important points, especially the culture that will change, even including different regions, which is very important. The epistemological aspects as well, like depend where we are, the knowledge we're working with. And then one thing very important, just like research, I'm on the research perspective. So when we have negative results, it's like, oh, how can I share this? So it's very hard. So you bring your perspective that, yes, we have to continue find different metrics, but it is difficult. And so let's see how it works on the field, because enjoying that. Wanda, I will bring to you your experiences from your field reality. So what are early signs from your experience that indicated the increasing of the spillover risk? And also, are there ecological or animal health indicators that already function as early warning for us?
Yeah, so thank you for that. I maybe just want to also just comment on what Osman said, because I think it's also relevant if we look at the field reality, and that is about systems. So some of the work that we've been doing in the Lancet Commission on prevention of spillover, we looked at certain important systems, for instance, wildlife trade, intensified animal farming, and then also where wildlife and humans share an environment. And your points where you can intervene in the system that will be linked to indicators will be, for instance, very different in these three systems. And this is just three that I'm mentioning. There's quite a few others. So I also come back to that you actually need to at least have some understanding of the presence of the pathogens in a system, because they have different routes of transmission, they have different disease or infection patterns that you also need to understand for that contact interface. So I think one of the things in the field that will always stay a reality, and this is sometimes a point that's debated, should we do pathogen surveillance, or should we just focus on these drivers and think we solved the problem of spillover prevention? But I do think one of your early signals need to be wildlife, because most of the source hosts are wildlife species. And this doesn't mean that we need to go and sample all the bats in the world or all the rodents in the world. We need to do some kind of risk assessment and identify sentinel surveillance sites where you can pick up risk early. So the frequency of your pathogen detection in source hosts, what we previously called reservoir species, is important. And if that's increasing, or if it's seasonal, or trying to see what's going on with the infection dynamics, is really important. And then you have to integrate that data into all these other drivers of disease emergence. And I think that's where this becomes complicated, because on top of that, you can't just say there's Marburg virus in the system. Yes, great, there's Marburg virus in bats. Hasn't spilled over yet. How are you going to know what is the reasons for it to spill over? And that there's maybe things that you then have to look at, like the rate of habitat loss or fragmentation, specifically in the Marburg example, the increase of mining in areas and how that's disrupting that integrity of the ecosystem, and monitoring that, because in areas where you haven't seen spillover, but you have these pathogens, that may be an early warning sign if you start seeing this degradation in these high-risk interfaces where some of these pathogens are are present. And that may be different for something like Nipah virus, where people drink date palm sap, and that is the reason that spillover happens. So we have to think about context specific, but also know where the pathogens are present and have some sentinel sites. Then I think the other really important thing in terms of early warning is human behavior and changes in human behavior. For instance, South Africa, we've got Marburg virus in bats, but we have very limited interaction with humans. We don't have bats on the market for people. People don't eat it, they don't hunt it. If that situation suddenly changed and we're not watching human behavior in these high-risk interfaces to see when there's behavior changes, we won't see those early warning signs until we see disease or spillover of these pathogens. So that's maybe just a few examples that we can look at. I think that is some of the early warning signs that we really need to look at. Look at the pathogen, look at the ecological things, and look at human behavior. Learn from other regions, where some of these pathogens have already spilled over and caused human disease and deaths, and see what those indicators are that cause that, and monitor that in other areas as early warning systems. Over.
Thank you, Wanda. It's very interesting that what you brought, your experience in the field in Africa. I'm from Brazil and Latin America. So even though we're in different regions, we have similar examples and similar worries that we have to think about it. And one of them is the wildlife trade and the wildlife, since the source, we have to start intervening, and especially the communities, how the communities are going to work together, how we are going to work together all the way for this interaction. But yes, it's very important, your experience with the wildlife and the spillover prevention. So since we're going to talk a little bit about the prevention and this prevention of the spillover before the outbreaks, I'll bring it a little bit back again with the economic value. So Marc, bring your experience also. How can we quantify this added value of prevention and reduce the probability of a spillover before outbreaks occur?
Yeah, I think if we go back to what Wanda was saying in terms of the variables that can directly influence the spillover, you can put this into modeling systems, combining ecological, as Wanda said, about maybe habitat for wildlife, or maybe farm systems when you're talking about zoonotic diseases from farm animals. And you combine these ecological mechanisms with epidemiological mechanisms and also economic dimensions, and you can assess the risk reduction you could obtain if you put together this prevention strategy. And so I want to be very clear here. We're not talking about the added value in terms of cases avoided, because this would be going too far down the causality line. But you're talking about reduction of a probability of spillover. And then you can add this to what we, in environmental and health economics, we call the estimation of the burden in economic terms, which means that we are trying to translate many dimensions, whether they are from related to health or related to the environment. We're trying to translate this into monetary terms. So this echoes what Osman was saying before about the necessity to give some economic value to ecosystem health, because this is something environmental economists have been doing for quite a long time, depending on the ecosystem service you'd like to value. But you can also, and I'm really sorry about this, but you can also give some value to health in monetary terms. And, economics is known as the sinister science. So sometimes we're not afraid to put value, not a price, of course, but to put value on health, morbidity, even mortality. And if you bring this together, you can put this with the reduction in the probability, and you can assess the avoided losses in monetary terms. And this could be interesting in terms of indicators, because as we all know, when you speak in dollars, people tend to listen more than when you speak in terms of wildlife habitat or even in human health. And just to give you an order of magnitude from a paper that Wanda and her co-authors published recently, they estimated that investing something between $10 and $31 billion in primary prevention could spare the planet from pandemic risk. And this pandemic risk is estimated in terms of tens of trillions of dollars. So we're talking about like a 10,000 return on investment. And I mean, who wouldn't want to have 10,000 times return on his investment? So this is something, obviously, we're far from achieving this in terms of policy, of convincing decision makers, but it gives you an order of magnitude of what you can achieve if you come up with those indicators. And I'll just add something on the co-benefits that Osman was mentioning before. The co-benefits are interesting because you could actually use them to maybe not overcome, but at least go around the prevention paradox, because you can really show something very concrete in terms of climate, in terms of biodiversity. You've invested in prevention, but you also have something else to show for in terms of reforestation or biodiversity increase and other co-benefits like this.
Thank you, Marc. And as I am a teaching professor, I always teach OneHealth, and I share with our students that when we had the outbreak, COVID outbreak, and the money that was spent, it was, as you mentioned, much higher than if we could prevent. So you brought very clearly, and I always share with them, like even with the numbers, it's how we call economics health. How even a prevention in economics will bring the health, and as you mentioned, all the co-benefits that brings with the productivity, biodiversity, and climate as examples you gave. Thank you very much for. And just one more question also. How should we incorporate the cost of inaction into the prevention indicators?
Oh, yeah, that's an interesting point, because people tend to talk a lot about the cost of inaction. For me, it would be it's a good political argument if you want to speak in favor of prevention, but you have to be careful, because if you're trying to assess in a sincere and a robust way what inaction is, you really need to incorporate, when you compare it with your prevention action, you need to incorporate in your cost analysis all the costs that are incurred by prevention. So it means that you need to do a big effort in terms of assessing those costs, which can be communication cost, which can be coordination cost. We talked earlier about surveillance systems. And so if you want to use cost of inaction as a political argument, you need to be very thorough in terms of the cost that are caused by prevention. So in the end, I guess the question is not that we as economists should always prove that prevention is better. It's not the question. The question is we need to identify the risk situation and all the externalities, the effect on different sectors, and the order of magnitude of the losses that will be generated, in order to show that in this particular situation, prevention would be absolutely efficient, which can be very often, but you need to do it in a robust way so that decision makers will actually trust that your assessment is based on a thorough analysis.
Well, thank you very much. And that's why, as part of the OneHealth of working interdisciplinary teams, that's why, as a veterinarian and you as an economist, we have to work together, because certain is like, oh, I thought it was the opposite. So great, thank you for clarifying. Very, very important. Let's think now, since you brought some very important costs for these thoughts. How we're going to do, and now I'm going to ask Yoeri to come and help us. How do we, thinking now about methodological evaluational framework, how do we build credible methodology to compare a One Health prevention approach with the sectoral approaches? And since we're talking about methodology, what are the methodological limits of return on investment indicators in prevention? So bringing the economy and the methodologies. Yoeri.
Yeah, thank you. If you talk about a challenging issue is how to combine this into a methodology that actually works in terms of investment appraisal. And if you look beyond that, also is suitable to build an evidence so that we can learn from cases elsewhere and use that economic evaluation and economic appraisals to make other prevention decisions easier. And I think the essential words, if we talk about economic appraisal, is that you need to compare. So it's all right if we can look at a single intervention and see what the cost and the outcomes are involved. But if we want to facilitate a decision-making process, we need to compare options of investments and select the best option in that specific case. And if we go a little bit beyond single sector intervention versus One Health, therefore, and Marc already mentioned it already, the cost of inaction, and Osman mentioned it already, what happens if we do nothing? If we want to present the true value of prevention, we need to consider, even if it's practically speaking, it's maybe not an option to do nothing, but we need to understand the consequences if we do that, because that shows us the decision, should we intervene in by investing in prevention? Well, if we decide to do so, then we need to compare a single sectoral intervention, for instance, to a One Health approach. And therefore, we need to understand that a One Health approach looks beyond outcomes in the single sector, but it tries to explore how the whole health system, how it functions. To build a methodology, we need therefore to consider expertise from multiple perspectives, like we mentioned already, from different expertises and different sectors, and try to map or indicate what type of consequences are being influenced by the specific intervention, and see if they are beneficial or if they have potential negative side effects. Based on that, we can together understand a little bit what effectively will be caused, or will change in how the health system functions if we invest in this prevention. And if we look at single sector intervention versus the One Health approach, then we can consider, is there additional value that we can achieve by applying this collaborative approach, and is the value that we retain from that, is it worth the additional cost to have this One Health approach? So that's quite fundamentally, in terms of an economic appraisal, how we can look at this. If we look at methodological limits, I think there's one fundamental one, and that it's very hard to monetize all of the indicators. Some indicators simply are very hard to put into money. We can try for a certain amount to do so, but there is some uncertainty involved. But if we do this for the whole system and the whole function of the system, then we need to be very careful if the output, if it's still representative of the value that we can create. And the same goes in more practical application. We cannot quantify all of the impacts involved. Mainly due to budgetary issues often. We cannot do that, and we should not do it. Therefore, it's not always the sense of a problem to quantify, but we need to make sure that we do not have a false precision when we communicate the results. When we interpret the results, which we can quantify, we need to be very distinct and very open about the limitations and the scope that we had under investigation. So from that sense, methodologies are often multi-layered. You can have a quantitative part, which we can control and which we can validate and which we can interpret, and a qualitative part on what we know from scientific theory, how a system functions, that helps us to interpret these results, and if it's well designed, that helps us all facilitate the discussion on what is the best investment option. So I will close it with that.
No, that's very, very good. Thank you for bringing that. And I'm going to bring now, since we're talking about, again, sometimes it is money, sometimes it's not, but how important it is that sustainable funding for all this to continue. And just briefly, Marc and Osman, if you can bring your experiences related to funders, share with us, for funders and development banks and national governments alike, what types of indicators are robust enough to justify investing, including loans and zoonotic prevention, and our current appraising framework for grant funders or governments to focus on short-term, easily measurable outputs rather than long-term risk reduction and systemic stability. And so we're just, because we're talking about economics and money, if you can be very briefly, but then Wanda, I'll come back to you because I have one question for the field work. But I just wanted to bring, since Yoeri just talking about funding. Thank you for.
Sure. I'll be very brief, as you asked, Christina, and very blunt. This is something I learned during my visiting stay here at Agence Française de Développement. When you're talking with borrowing countries or with development banks, maybe the Minister of Health is already convinced that prevention is a good thing. But who you actually need to convince is the Minister of Finance. And I'm sorry, but this brings us back to economics, because if you can show the Minister of Finance that you have a plan that will reduce a risk that can be seen as a systemic risk. We talked about COVID. You talked about COVID-19 before. I mean, we're talking about an upheaval for the whole economy. So if you can show that this investment on risk reduction is actually efficient, then maybe you'll get his ear or her ear, and you'll get this prevention action put together with then the other ministers, such as the health ministry.
Thank you, Osman.
I'll come in and just throw a little bit of cynicism into the discussion, I think, and I do that because the realpolitik of a lot of decision making by donors and funders is we make an incorrect assumption that we're all after the same thing, and donors and funders, often from high income settings, view risks very differently to risks as they're viewed in sort of low and middle income settings, and that's one of the big, I suppose, ironies or tragedies of securitizing health and securitizing global health in particular. That yes, it has drawn in more money into the public health and the health sector because there's a security element around it. But it's also meant that the focus or the reason why donors are giving money can be sometimes skewed. It's the risks to themselves, right? So, for example, if you take something like, I don't know, antimicrobial resistance, you might find that many of the most effective interventions are on the prevention end of the scale, right? So big vaccination programs, improved water and sanitation, improved nutrition, clean air. All these big kind of preventive interventions mean that you require less antimicrobials and antibiotics because you have less infections, and that is the best way, a most effective way of dealing with AMR. But all the investment from donors is actually around the surveillance, the monitoring, the lab systems, because they're afraid or worried that those antibiotic resistant pathogens will come into their jurisdictions, right? So they want people in a low income setting to be monitoring very carefully in their tertiary healthcare facilities whether or not there's an AMR bug there and what is it resistant to, because they're worried it's going to come into their jurisdiction. So they're not interested as such in so you can go and present as much of an economic argument around return on investment as you like, but if it's if it's specific, if the idea behind it is that we actually want to prevent this infection coming into our jurisdiction, that's the real reason why the investment's being made. So you have to frame your entire case around investment around that. So I'll give you a really good example from my own experience. We were in Somalia doing the zoonotic disease prioritization workshop there, and it was a very interesting process. You know, they ranked everything on a whole set of different indicators. What are the most important zoonoses in our setting in this country, and from that, given their circumstances, avian flu ranked something like 29 out of 32. Okay, it was way down the list, and at the end of the meeting, and they'd gone through this evidence-based, consensus-based process to come up with the list. At the end of it, the decision makers within the group, within the ministries, the three ministries, came together and they said, actually, we're going to elevate avian flu up to number 7 so that it's in the top 10. And it's very simple reasoning. They said because the donors are interested in avian flu because that's what they're worried. They're worried about flu coming into Northern Europe or North America, and so we need to prioritize it. 99% of our funding for the health sector comes from donor funds. So it doesn't matter. We'll throw off enteric disease or whatever it was that was number 7. That can be bumped off because actually we need money for the whole of the health sector. So there's what we're talking about, which is obviously a science-based thing, but then there's the reality of what donors and vested interests are in this space. So I mean I'll pause there, but it's the reality is not always based on what we would like it to be, evidence-based, science-based practice, and the notions of equity and things that you're talking about. In some donor circles now, equity is actually a bad word. If you say equity, you will not get any funding at all. And I see Wanda nodding, and this has happened across multiple funds now. If you put any label of equity into your funding application, you won't get the funding.
Wow. Thank you for clarifying, both Marc and Osman, the reality, right, that is going on with the funding. And that's one big challenge in OneHealth that we face. But because you brought this very important in the funding and the funders, and we have to write it down, I would like to bring to Wanda, since we have already the frameworks, the existing frameworks, and of course, all the different countries already struggle with multiple indicators, frameworks such as the international health regulations, such as the joint external evaluation, the climate. Should we build new prevention indicators, or better we continue existing ones and learning from Osman, Marc, what to say in our grants or not to say on our funding?
Yeah, so my personal view on this is that we really need to look at the frameworks that we already have and adapt that. I think one of the important things is having the right people around the table that needs to look at these indicators. So if you do the international health regulations, you need to make sure that your Department of Agriculture, your Department of Environment, and your Department of Health are feeding information into these very broad global indicators. And one thing we need to recognize, I think, although I say let's use indicators that we already have, we had this discussion recently in South Africa when we were doing our OneHealth framework. And one of the things people begged for is not another framework. And because we can't just do more meetings and more meetings, we need to start consolidating. But we also need to recognize what some of these current frameworks were designed for. And if you, for instance, look at the OneHealth or the international health regulations, it's got a very public health focus. So although there's things that's relevant in the prevention space, that's obviously not the focus. So there may be opportunities, especially with the pandemic agreement, that some of these instruments can be revised, because in that agreement, there's 4 quadripartite organizations that are requested to work together and look at things collectively, if we talk specifically about One Health and prevention, but also for countries to bring their different ministries to the table. So if we look, for instance, let's just think about the IHR, which is what everybody has to do. Member states have to look at these indicators and report on them. There is things about surveillance, your laboratory systems, your risk communication, your emergency response, even things about port and border control, where pathogens can enter countries. Your zoonotic events is probably very relevant to this discussion, but it's the indicators in the IHR is very much on the reactive side. So it's when the disease is already, when there's already disease. It's not prevention where we understand what's going on in the source host and in terms of drivers of disease emergence. So there's not a explicit focus on primary prevention and spillover prevention. It's more preparedness and response, but we can use it also to address some of these issues. Specifically, if you look at the specific sections on zoonotic events, because it brings in One Health, at least now in some of these IHR indicators, we have to have One Health committees, One Health strategic plans. So it can be used as opportunities to also look at prevention, either by rewriting it or just using it on a member state level to also have these discussions and get information from the different sectors. Integrated surveillance is in this, although I think there's still a very big gap with bringing in what we will call environmental aspects, but it's actually your drivers, your climate indicators, your land use, your biodiversity, wildlife trade is obviously not going to be in there, any indicators on that. So there's some room for improvement, but I do think we need to recognize that we can use some of these indicators and bring in what is now in the pandemic agreement, I think under Article 5 and 6, if I remember correctly. We will have to find a way to monitor those things if we agree to the WHO pandemic agreement as member states. I think the JE is very much on a country's capability to prevent, detect, and respond. Although I think the way we understand preventing the JE is not necessarily primary prevention. It is sort of using vaccines to prevent it from spreading in humans or in animals. But the core areas, prevention, detection, response, and health security risks are there. But again, I think the ecosystem environmental focus is completely missing in these instruments. And if we talk about primary prevention, that is essential. Ecosystem changes, wildlife trade, high-risk farming systems. I don't think that's really addressing. And then also the socioeconomic drivers is not really brought into any of these instruments. So I think, yes, we don't want to create another framework, but we will have to look at what we have and how we can bring maybe some of the climate frameworks into this space, because there's also some, I think it's the Paris Agreement, there's some UN frameworks that we have to report on climate indicators that can also feed into the space and maybe do some kind of collective indicator. But I saw there was a comment in the chat. It is very geographical specific. So you have to look at context, you have to look at geographic specificity, but we do that with the IHR and the JE. It's very broad questions, and then you bring in your country information, and you do you measure it based on very specific information. So yeah, but it's probably not everybody's view. It will be good to hear from the other panel members. But that will be just because of the burden of doing all these indicators and measurements, and then people are anyway not going to do it properly if we have too many of these over.
Yeah, then that's fantastic, Wanda. And that's you brought the very two important aspects, especially for the systems thinking in One Health and the interdisciplinarity. How important is the culture, the country regions, even though we're different, we have similarities, but it's very important to bring that aspect, as you mentioned, and as well the environmental. So we keep forgetting to bring that, but for the pandemic agreement and the pandemic funding, bringing both together, how important those aspects are. And since we're still talking about metrics and we're trying to find the indicators and also the frameworks, I'll bring a little bit more the quantitative and qualitative aspect for this discussion. And I'll bring it to you, Yoeri, if you can bring your thoughts. And how can qualitative dimensions such as appropriation, risk perceptions be integrated, since we're talking about this economic evaluation and funding as well, to the discussion right now? And also, since we go a little further, we're bringing to the policymakers. Are policymakers too dependent on quantitative metrics despite uncertainty?
Oh, excellent questions. Well, first of all, I think that we should not underestimate the value of quantitative outputs, especially if we talk about investment decisions. Quantitative data allows us to compare different options compared to each other. And we really need it. It's essential. And even if there are limitations in how we monetize it or how to deal with uncertainty, we can cover that by explaining how we get to that value and how we explain it. But in terms of prevention, we see that there's much more involved in the value that will be generated by prevention. And we cannot cover that by only using quantitative data. So we need to help with that interpretation with a qualitative layer around it. So for me, the process, if I look at the value of prevention, I would see at its core, it's a quantitative basis, something that we can monitor, that we can validate, that we can discuss and compare to other options. But around that, to interpret that quantitative data with the uncertainties that come with it, we have a layer of a qualitative knowledge of how the system functions. And many of this we can validate from other research or theoretical knowledge how systems behave, which can help us by interpreting the benefits of a specific intervention. Last year we did, from a OneHealth evaluation, we did on dairy value chain development in Senegal. We had a workshop, a validation workshop, where we had a quantitative basis and an economic valuation of an investment. But in that session, we had like a mapping, an impact mapping, with people from all the ministries involved. And we gave a picture of the intervention, on the benefits that it had, and let the participants from all the ministries say, okay, what does it mean for your department? And then you see some interactions. And even though this was on value chain development, something like biosecurity, it came up immediately from all of the angles that we knew, from the environmental angle, human health, but also some financial implications. What happens to our economy if we have a biosecurity threat from this? Can we cover that with this intervention? And with that layer, and if we understand how this system behaves, well, we can show this value to multiple audiences. So as Osman said, from what is invested, of what is important to funders, we can at least tip it in our evaluation and say, okay, here is value. And on that quantitative core, at least we get this result, but we also get benefits in this and this and this area. Well, and if we go a little, even a step further, because this is the second layer, would be around the knowledge we have on the system, which we can say with quite some certainty. But around this are the more indirect consequences, which may help to sectoral development. And this is what we expect that will happen, because a single intervention can contribute to an infrastructure that can have a positive impact on other developments as well. So with those layers, and if we be specific about how we phrase them, so we do not give the same certainty to each of these components, then we can explain, okay, we know this type of benefit we will yield. We expect it has these benefits in these certain areas, and it might have even more consequences later on, which generates a general stability, etc. And that, I think, might help different audiences to defend the decision to invest in prevention. So if the question, if our policymakers at the moment too much dependent on the quantitative data, I think many of the regulations force them to defend decisions based on quantitative data. But I think it's the responsibility of all of us who provide that quantitative data to also facilitate discussion on how to interpret it, and hopefully we can make meaningful progress in that regard.
Thank you, Yoeri. And since we're just to bring to our conversation Wanda and Osman, if we have 2 minutes per person to bring this, since it's very this aspect, comparability and context, is it possible to define a minimum global prevention indicator set that remains comparable across setting while avoid one-size-fits-all metrics? Wanda and Osman.
You want to go first, Osman?
No, go ahead, Wanda.
Yeah, so I think you know, if we look at the public health space, we've done it with the IHR, we've done it with some of the climate indicators where there's one set that we make available globally, but then with the I don't want to really call it flexibility, but with you can use your own regional information to report on this. So you need that regional context to actually report on the IHR and the JE and your capability, although it's very broad indicators. So I do think you can make it very broad. The question then is it too broad to actually do something with it? I think from the economic and the finance side, people will say, but then you don't have real data that you can actually predict maybe to funders what will be the investment case or will the interventions actually work. So it's maybe a bit broad, but maybe an example from South Africa. So I'm with the Future Africa platform also at University of Pretoria, which is a transdisciplinary platform. And we just launched the regional hub for the Lancet Countdown for indicators, mostly linked to climate, but we're also going to try and bring in prevention and everything. Now, what's important there is there's a one for Africa. It's not like there's only the global countdown, Lancet Countdown indicators. And the reason for that is really to look at if those indicators are relevant for the African continent. So I do think there's a case to be made globally, but maybe also at least regionally or similar type of countries that can have more specific indicators may be a way to go. For instance, measuring things in Africa is very different from measuring indicators in Europe. And if you don't make it specific enough and say you need to get regional indicators, people will not collect the data, because we will just always use global data to monitor things. So I think there's value in making it more specific and not just globally, also maybe regionally and maybe even context specific to specific problems in country. Over.
Yeah, I just add that I mean for me, I think how can I put this? I think certainly around process, you can have some global prevention indicator sets. So around process, you can have comparability done there, but even if you look at the ones that are most typically used, the joint external evaluation or the PVS assessments, those are not designed for inter-country comparison. They are designed to set a baseline within a country and then to monitor progress against that baseline. They're not meant to be used for inter-country comparison. So, like a perfect example is if you look at radiological hazards on the JEE and the measurement of those. This is in the other hazards bit of the joint external evaluation. If when we first did it in I remember one of the first JEEs was in Pakistan. So where they were looking at nuclear and radiological hazards, and because all of those were being dealt with by the military because they have such a highly specific, highly secure nuclear program under the military, they scored 5 out of 5. But on the other side of the world, in the United States, when they did theirs, they scored 3 out of 5. And that's because they have so big a nuclear program, so many radiological facilities, uh, and under so many different agencies and so many different ministries. They're not all speaking to each other. Some are secret, some are not secret, some are for civil, some are for hospitals. There's hundreds and thousands of them. But it's meaningless to compare the two countries on the scores then, if you see what I mean. They're so context specific. So if there's specific indicators around process where we know there's an evidence base that, um, X, Y, and Z intervention or capability means you have improved zoonotic disease control. So, it could be things like integrated disease surveillance coverage or cross-sectoral data sharing or laboratory capacity across human and animal health. Then that's fine. Those are the kinds of process type metrics where you can make inter-country comparisons. But really what you need is more like a two-tier indicator framework, a global core indicator set for comparability around these kinds of process indicators, but then something combined with context-specific indicators tailored to local ecosystems and local ecological drivers, sort of like Wanda was saying. And I mean, I like using labels and stuff, but basically this speaks to the idea of doing really good life cycle analysis specialized to particular ecosystem. So you define your ecosystem, and then within that, what is the life cycle analysis for a product, a pathogen, or a pollutant, right? So from the production of that product or pollutant to its eventual destruction, and the same with a pathogen. You define that ecosystem and or environment, and then look at the entire life cycle within that. And all the risks and drivers within that, and then and you use that as a baseline to then make comparisons later on. It's really actually quite unhelpful that I found to make intercountry comparisons, especially, and we give ourselves this false sense of assurance that, oh yeah, we're doing something really clever, but actually a lot of the stuff is so context specific, it's meaningless to try and even draw comparisons.
Thank you, Osman. And since you just mentioned about political economies, I would like to bring Marc and Yoeri to share with us, if you have 2 minutes per person, and thank you, Osman, why do prevention indicators often fail to influence budget decisions, even when economic evidence exists, and what political economy constraints are at play? We're going to have another webinar just for that. So today, if we can just start the subject, 2 minutes each, Marc and Yoeri. And thank you, Osman.
I'll try to be brief. And I think it's interesting because it echoes Damien's question about the role of economics compared to politics, because in the end, you can actually end up with a bottleneck where political decision is not based on economic analysis at all. It will be based on other factors, power structures, dynamics, stuff like this. So I think we have to come back to Osman's point earlier, which is, are we actually talking about something that is relevant for the given territory, the given country, trying to prevent this zoonotic disease? Because maybe you could actually demonstrate that there's a positive return on investment for prevention, but you could also be aware that this is not at all a priority in terms of health expenditures for the country, and maybe child diseases are much more urgent to treat. So you have to go back to the actual necessity of trying to prevent this zoonotic disease. Then in terms of more classic political economy issues, well, you have linked with the prevention paradox. We are all aware that political cycles are much shorter than a prevention cycle that would give benefits maybe years or decades later. So this is something very hard to make compatible with the actual motivations of politicians when it comes to investing in prevention. It's in every kind of country all around the world, it's always better for your next election if you have a big shiny hospital rather than a prevention program that no one really understands, or that the results are quite difficult to grab, because those results can be, as we discussed, just zeros. And this is something politicians who would like to advocate prevention might also try to do. It's improving how you communicate on zeros. I mean, a zero can be a good thing. So we should try and think about how we can frame those zeros in more positive terms. And then there's the idea of the fragmentation of the political decision. And we mentioned before that if you have a Ministry of Finance on the one side and then you have a health ministry and the agricultural ministry, the power can be divided and people don't want to invest resources if the benefits will be shared across the whole governance structure. So you can have also some power issues there that need to be addressed.
Thank you so much. Yoeri?
Yeah, I can totally echo what Marc mentioned. Of course, in political discussions, there's always a limited amount of funds available in a limited budget. So the decision needs to be made where to put the money, and there's always some issue that requires imminent action, and that's fairly easy. And if you look pragmatically about it, at that point in time, it's the right decision to invest in that. So to explain the case of prevention is basically an insurance, whereas we would like to have tangible results on the short term, which we can explain, we can see what we can get for our money. And that's quite hard to communicate to, for instance, to voters. And then there's, of course, the other issue, and it's more macroeconomic. If we talk about prevention for pandemic prevention, the value you generate is for beneficiaries that are outside of the scale of your investment. So you basically are investing in a global public good. Whereas if money is limited and you need to consider that as an integrated part of the decision, it's fairly hard to decide to invest in this prevention where you do not know if you have a result, because hopefully you won't get any results. Compared to investing directly in an imminent action that has a tangible result on the short term, I can understand why most decisions would go on the other way, even though economic evidence is available.
Thank you so much. And because we wanted to open for the questions from the audience, I just would like, if we have 30 seconds to all of us to participate, and I will also please bring back Catherine and Elsa to join us. But if you have 30 seconds, if you had to prioritize one indicator that would make prevention financially and politically sustainable, what would that be? Wanda, let's start with you.
Yes, I think in my 30 seconds, for me, it is there a multi-sectoral One Health coordination system, and what is the political support for that? You know, it needs to be on a high level. Somebody talked about the finance minister. It should probably have access to that. But I think if that doesn't exist, none of these other things can happen in a country, and also not on a global level. So really a strong and functional multi-sectoral One Health coordination at national as well as subnational level is critical as an indicator. Over.
Thank you. Yoeri?
Yeah, I'm a bit boring. I would say I have none in terms of priority. I think it's a fundamentally complex system, and to capture the true value of that prevention office, to capture that in one indicator, we cannot do it. Sometimes a simple question like why should we why should we invest in prevention will yield a very difficult answer, which we should not simplify.
Exactly. Thank you, Osman.
So I was thinking about this and trying to go up with something. And well, what I came up with was something to sort of bridge all the different sectors, right? And since we're talking about prevention of a spillover event, I was thinking that at least something useful that can be turned into something measurable would be the time for pathogen detection in animals or the environment, the time taken for pathogen detection in animals or the environment, to a documented and coordinated cross-sectoral response. And that response could also be just documenting that actually we've detected this and we don't want to do anything, but that counts as a documented coordinated response. It might be that you decide to intervene and do something, but it has to be documented, it has to be cross-sectoral, and there has to be some sort of acknowledgement that you've done something. So the time taken to detect it in the animal's environment to that. And then that sort of encompasses a lot of things, encompasses lab capacities, encompasses the level of coordination, but it also ultimately answers what you're trying to get at, which is detecting a pathogen or priority zoonosis in animals or in the environment.
Thank you. And Marc?
Yes, and maybe I'll take it to a higher level in terms of basic priorities, because if beyond prevention, no one is going to invest in health if health is not considered as an essential priority in terms of human progress, civilization in general. And we're living in times where, unfortunately, this doesn't seem to be as obvious as it should be. So I think if we can come back to a sort of general indicator that humanity needs to be in good health, and that people actually agree with this statement, then there could be a basis to develop prevention and other aspects of health as well. But if we disagree on this, then it's going to be very hard to convince people to invest in prevention.
Thank you very much. As we can see, we can apply for a grant today. And all together, I'd like to open to the questions, and would like to bring Catherine and Elsa to continue, and also to have the close remarks. So we can continue next webinar. Thank you.
Thank you very much, Christina, and thank you all for this very fruitful discussion. So we now open the Q&A box. We had a lot of comments and questions. We won't be able to address all, but let's try to select a few of them. We had some questions from Max and supported by Nitish from Bangladesh. They indicated that they are struggling to find indicator for prevention in some specific OneHealth project. And wanted to know more about, the possibility of gold standards indicators that already exist or that can be applied to specific projects. So thinking about these indicators before even designing the project or while you are designing the project. So any of you want to address these questions from Max and Nitish?
Maybe I'll just add from a development bank point of view that you have to be very cautious. And as one of my colleagues already said, I think it was Wanda, there are already lots of frameworks, already lots of indicators. So if you add up a layer of OneHealth indicators, it might actually hamper the dynamic, because people are going to feel like there's too much pressure. So maybe what you want to do is transform some indicators that already exist and add the 360 vision that comes with OneHealth, which was also mentioned in one of the question by Gabriel. I think the idea that you need to have incentives for any kind of actors beyond development banks. It can be also decision makers, researchers, to adopt this 360 vision that will make sure that you envision all kinds of risks.
Thank you, Marc. I don't know if any of you wants to complement Marc's response.
Yeah, maybe just in addition to that, I agree. There's several. There's in publications. There's global ones. You can sort of pick what you want to use. But I think it makes it very complicated if we add different layers. I do think what I see is missing is probably more economic indicators, and we can't get to the indicators if we're not collecting data in projects on economic value. So I think sometimes it's more of a data collection that can feed into indicators in the future than worry too much about developing indicators. And I think important things is interventions effective, and how are you measuring it? And there's several ways that you can measure that by doing social work, or you can look at the economics. But I think when I'm in OLAP, one of the big things was always there's not very good economic data, because we come at the end of the project and we've done the interventions and we forgot to collect all the information to show how it actually saved money, or what is the cost benefit, or even the trade-offs of things that we're doing. So I think that is important to think about in projects, and that will be very context specific again, depending on the project. But I see Osman is staring at me, but maybe he's got a different idea.
No, I agree. No, I agree.
Carrying on the questions from the chat, I'll go back to well, actually Max has been very prolific, and questions from Manu and Max talking about how to move to this this really radical paradigm shift that we are currently encouraging. How to shift in this in our economy. So how can we really combine environmental, social, economic dimension all together and really make this move? I know Yoeri, if you have you're part of this community of practice, so you have quite a lot of input from this community on how to really have this this shift in the current economical paradigm that we have.
Yes, a good way to advocate the community here as well. I would like to share a link in the webinar chat later on for those who are interested in following. But this is exactly what the type of things that we discussed there. So how can we learn from each other what works in terms of a paradigm shift? And essentially that's what it is. If we know cases, how it works, how we can convince funders, policymakers in their decision-making process to shift from what we do now to what works better to advocate the investment in prevention, then we can apply that elsewhere and can use this evidence base to support future decisions, because that's the main way how to reach a new paradigm. We need to understand how to support these decisions and how to validate the decisions we have made, why prevention works, so that everyone can trust based on that evidence base. That's, for my opinion, the only way how we can reach that. And therefore, we need to collaborate. So even if information is fragmented and very geographically specific or based on culture, there are some elements and patterns that we can extract from that and validate if it works the same in other circumstances as well. But only if we communicate that value, and therefore we need to build this evidence base. And I think that's a very good first step, and take the lessons from that to move towards supporting decisions in another way.
Thank you, Yoeri. Anybody else wants to add to Yoeri's response? Yes, Osman.
I'll just add that for me, and a lot of the big drivers, the big social drivers, human drivers, are based on power dynamics, right? So who has greater political power, who has greater purchasing power, and globally, that's what drives a lot of spillover risk, right? So if you're thinking, for example, around, I don't know, intensified poultry systems, right? What we used to eat in Western Europe in terms of poultry 50 years ago is entirely different, completely different to what we eat now. So, I think people used to eat like one chicken a month or something 50 years ago, and now it's two chickens a day. I mean, that's the level of difference in the cultural change or adaptation just over the last 50, 60 years. And so it's and you have to look at where's the global power and purchasing power in particular around these things. And that's what's driving markets, that's what's driving industry, that's what's driving land use change. And it's for us to then, educate our societies that these are things that need to change. If we want, we want a more sustainable Earth or planet with these reduced risks of spillover. It's those that have the greatest power and the greatest purchasing power in particular that would be driving that. You cannot ask somebody who's on a farm in Kenya growing carnations or long stem roses from monoculture to change their habit and stop deforestation and stop cutting down all the trees and stop doing all of that. When it's us sitting in Northern Europe, I want to be able to go to the hospital in the middle of December and give somebody a long stem rose or a bunch of flowers, which have to be flown from Lake Naivasha in the Rift Valley, the day before to a flower market in Holland. And that's what's driving all of these kinds of things. If it's millions and millions and millions of tons of this sort of thing happening all around the world, that's what's driving these kind of outbreaks and these kind of spillover events. So, we have to look across the board and across the globe. If you want paradigm shifts like that, that's what has to change. But it's a hard sell in a world that's driven by power politics and consumption-based capitalism. And if anything, that side of it is getting stronger and stronger in the public discourse. So on that miserable, sad note, I'll stop.
I think this had to be said. Obviously, this change will only work if obviously everybody is thinking about it and reflecting on that. We have just a couple of minutes left, but I wanted to address one of the questions in the Q&A that could probably be a whole entire webinar by itself, but it was from Gabriel, who is a lawyer looking at the institutional adoption of OneHealth. His question was about how can we see these indicators incorporated into law? And would it be more on the substantive side? So how institutions need to consider different aspects, different factors, or would it be more procedural? Different agencies must develop, different working groups. I think these questions about norms, how to normalize this indicator, how to integrate it into law, could have a talk about that for hours, but in a few minutes, any of you want to address these questions?
Well, let me come in with one example. So I think it's both, certainly. On the substantive side, a really good example where you could integrate it into law, where it isn't at the moment, is around environmental impact assessment. So environmental impact assessments are sort of legally mandated whenever you're doing some big land use change project or an industrial project. So I don't know, for example, I want to build a dam in XYZ, we have to do an environmental impact assessment. But health impact assessment, and better still, OneHealth impact assessment, is not a mandatory legal requirement in those processes. And there's a wide scope around what constitutes a good environmental impact assessment. So you have to do it legally, but there's a very good quality one and there's a very poor quality one. And as I sort of said, health impact assessment is not a legally mandated part of that process, but it could be, and I think it should be. And certainly from a OneHealth perspective, you should have OneHealth impact assessments. So for example, as I was saying with the example of a dam, if you build a dam on a big freshwater river system, you can pretty much assume that depending on the location, schistosomiasis will suddenly shoot up all around it. People will move in, settle, and that's predictable. But that's a health impact assessment within an EIA process, right? So that is something that could easily be legally mandated and made something, that everyone has to do. So I just thought I'd share that as an example, but that's one easy win around the legal side of it.
Thank you, Osman. Marc, you have 1 minute.
Just to react to this aspect of trying to institutionalize or legalize such an approach as OneHealth, one thing we didn't have time to address during this webinar is the idea that at one point you also need to co-construct indicators with the people that are going to be evaluated by these indicators or that are going to implement the policies that will be evaluated by these indicators. So I think you should also take that into consideration to be sure that an approach such as OneHealth is actually accepted, actually appropriated by the stakeholders. And for this, you can involve the stakeholders at the conception level of the indicator itself, and maybe once again come back to some very context-specific indicator if that's what's needed for this OneHealth approach to be advocated.
Thank you, Marc. Thank you very much. We now come to the end of this session. I know, Christina, if you want to have a final word.
I'm just being grateful to be here today. A fantastic panel, as I mentioned. We're continuing another webinar. And Elsa, please have the closing remarks. Thank you, everybody.
Thank you very much. Well, I really want to thank our panelists, Dr. Osman, Professor Wanda Markotter, Dr. Marc Leandri, Dr. Yoeri Booijink, and our fantastic moderator, Dr. Christina Pettan-Brewer, for this very rich discussion. We couldn't address probably everything that needed to be said on this topic. I'm very sorry that we couldn't also answer to all the questions in the Q&A, but a recording of this webinar will soon be available on the PRESID YouTube channel. Feel free to share it with all your colleagues. And we will also have a very brief article to follow up on this fruitful discussion. Thank you all very much for taking part to this webinar, and thank you to our audience.